Thank you for joining for Rapid Antiretroviral Therapy. We are really excited that you are here and that you're taking the time to watch this video and to learn a little bit more about ways that you can engage in rapid antiretroviral therapy in your organization. But before we get started into that, I'd like you to just take a moment and think about where you fall kind of on this spectrum. So, the question for you is, how familiar are you with the rapid art process? So, the spectrum is you know it by heart, you're kind of somewhat familiar with it, maybe you know very little about it, or you're like, what even is rapid ART? Right? So just think about that for yourself as we're going through this to get an understanding of like where you're coming from and where you could be going with this. So I'm going to pass it over to my colleague to introduce themselves, and then I will introduce myself.
Hello, everyone, and thank you again for joining us for this discussion about rapid antiretroviral therapy. My name is Bev Wasserman, and I'm the nurse field consultant with the Denver PTC on the capacity building team. And I have been in nursing practice for many, many years and really enjoy working with health departments and clinics and all of our colleagues around the nation, in particular in this era of working on rapid ART. Again, our team does a lot of capacity building work on this topic. So Ms. Jai and I are so excited to get into this with you today, and hopefully you take away some new ideas in how you can implement rapid ART. Ms. Jai, I'll let you introduce yourself.
Awesome. Thank you, Bev. My name is Miss Jai. I am a subject matter expert with the Denver Prevention Training Center, and I have over a decade of experience working in HIV prevention and in HIV care. I've worked in hospital settings as a medical case manager and running a medical case management program. I've also worked in non-hospital settings and in community-based organizations doing testing, which is oftentimes where we meet folks at the beginning of the linkage to care process. So I have a little bit of the out in the field experience around what it means for us to connect folks to care when we are maybe conducting testing at a bar outreach or out in the world. So I'm really excited for us to have a robust conversation today. Here are our learning objectives for this video. So we're going to accomplish these by going through what rapid ART is and its connection to the National HIV Strategy. This will then be followed by a section on eligibility criteria and how to identify potential candidates for rapid art in your program or your organization. And then we will go through two different approaches to rapid ART, an immediate initiation and a 7-day initiation. Finally, we will discuss how linkage to care becomes more condensed during rapid ART and some considerations for different sites that are wanting to launch a rapid art program. So I'm going to pass it over to Bev to introduce us to rapid art.
Okay, so here we are. We're going to get into what are we talking about when we say rapid art. So I'm sure many of you, and if you thought about that poll question that Ms. Jai asked you as we began, you may have thought, oh, well, we're starting a program or we do things to get our clients and patients on rapid ART, but we don't call it a formal program. Or you may be thinking about starting a rapid ART program. So we, again, as we think about this national strategy, we know it's really to help us coordinate care and make sure, again, that we're working together strategically as around the nation, really, using all of our different skills and talents to really get our clients connected and on meds as soon as possible. So again, according to our national HIV/AIDS strategy, programs focusing on immediate, ideally same day or within 7 days start of ART have demonstrated success and continue to expand around the country. Again, everyone is not engaged in a formal rapid ART program, but we hope you'll consider ideas to just think about whether you call it that or not, getting your clients and patients on meds as rapidly as possible once they've been diagnosed. So again, as the national strategy is our guide, it's really our beacon, if you will, that tells us again what we're doing as we look to really follow this strategy. And we understand that our work in supporting communities impacted by HIV is to focus on these efforts that NHOS has created for us. NHOS again focuses on preventing new infections. We do that when you think about starting your clients and patients on meds early, then they actually reduce their viral load and they have less, almost zero opportunity where they would be transmitting HIV. So that's a great thing, right? And then, of course, it improves health related outcomes. We studied this many, many years ago in HIV treatment and found getting people on meds right away really improves long term health outcomes. It reduces disparities, of course. Again, if we look at disparities broadly, we think about, well, if people don't have access to care, access to services, that can be a problem. And then, of course, as I said earlier, is that integrated, coordinated effort among all our partners and stakeholders. And we'll talk a little bit about who those partners and stakeholders are here shortly. So now we have a question for you. Think about, how do you think, we just talked about kind of this national strategy with all these amazing goals. How do you see Rapid Art supporting this national HIV/AIDS strategy? I'll give you just a few minutes to think about that and we're going to keep going. All right, so probably you came up with the same ideas we did. It really matches nicely. Getting folks on meds early really prevents new HIV infections, improves health outcomes, reduces disparities, and it helps us integrate and coordinate care. So again, we also think about a variety of communities that we serve. If people live in places, rural frontier communities, again, is an example where we may have to do a specific strategy. But this in-house model really helps us think about all these ways that this benefits our clients and patients and the communities that they live, work, and play in, as we say. All right, and then of course, I'm sure some of you have heard of ending the HIV epidemic in the US. This again is a national strategy. We know Rapid ART supports CDC's ending the HIV epidemic. We call it EAT for short, because it has these 4 pillars that Rapid ART nicely fits into. So we know we have to get folks tested and diagnosed first. When we talk about treatment, that's where Rapid ART plugs in. And then, of course, there's prevention of new infections and responding, whether it be in a community or to several people who may have been exposed and responding quickly. But it's all this effort that really helps us look to reach that goal of ending the HIV epidemic in the US. And then these are the Rapid Art steps. They look similar to our cascade that we talk about a lot in HIV, but this is just kind of laying out the order in which you might get people on Rapid ART. So of course, you want to identify clients that are ready and kind of in a mindset, in a space where they could start Rapid ART. We have to do some education, some post-test counseling. People need to understand, what does this mean for me living with HIV, and what's going to happen next? And then of course, the psychosocial needs assessment and referral is tremendously important, because without that, the other pieces really won't work as well. And we get folks lab testing done initially, and there's lab testing done throughout HIV treatment, of course. And then we get folks on the regimen and we think about follow-up. So this is just a way, again, to walk through all the steps that'll help us effectively deliver a Rapid ART program. So now Ms. Jai is going to help us identify how we look for readiness in our clients and patients when it comes to Rapid ART.
Awesome. Thank you, Bev. So, identifying rapid ART candidates for your program is a crucial first step in deciding how to implement rapid ART. And it may also help you guide the selection of the appropriate art model, which we will share a little bit more about in a moment. So there are two steps that we have laid out here to help you identify appropriate candidates for rapid art. And while I'm laying this out, I encourage you to think about where you might already be seeing folks who fall under these categories. So the first step is a candidate must either be newly diagnosed with HIV or be HIV positive and have no history of a previous antiretroviral therapy. If they have used antiretroviral therapy in the past, but do not have any known drug resistance, then that can also work if they are already living with HIV. So again, thinking about your program, where are where in your program are you first seeing people, or where they're first receiving their a reactive point of care HIV test, or that they might be diagnosed with acute HIV? And where might you be seeing folks who are trying to relink to HIV care as well, who are previously diagnosed with HIV? Because these are potential candidates for rapid arts or the rapid art program. The second step for candidacy is ensuring that the person does not have a medical condition or an opportunistic infection that may require a delay in ART start. So, not all opportunistic infections require a delay in starting antiretroviral therapy, and it is highly recommended to review the DHHS guidelines on antiretroviral therapy for persons with acute opportunistic infections and malignancies to help determine if someone is an appropriate candidate for rapid ART. But it's another consideration to keep in mind when you're starting a rapid ART program is when would we need to potentially delay start as well. If both of these conditions have been met, then the person is eligible as a candidate for rapid ART. So a question that I'd like you to reflect on, and you can go ahead and pause the video here, is where in the program are you currently engaging with patients or clients who may be eligible for rapid art? So you can pause the video, write down a couple of those places that you can already think of. As a reminder, these are the folks who are newly diagnosed or are HIV positive and have either never been on art or have no known resistance to art. So I'll give it just a few moments. Wonderful. So hopefully you were able to write down a couple of places in your program or in your organization where you might be coming into contact with clients who could benefit from rapid art. Some of the potential locations that we commonly hear about are anytime that someone is getting a rapid or point of care test. So if there's mobile testing through your organization or on-site testing, if there are any collaborative programs that might be coming into contact with patients who are HIV positive but are out of care, then those might be good collaborators to work with in order to engage in rapid art. If you're doing outreach in the community, you might be coming into contact with folks who are either out of care and are needing to re-engage in care, or if you're doing outreach events and testing as part of that, you might also be identifying new infections as well. So those might be folks who are eligible for rapid art. So those are all locations that might make sense. And with that, I'm going to pass it over to Bev, who's going to go through the two types of rapid art, immediate and 7-day start.
All right. Thank you, Ms. Chai. So again, for our clinical sites, considering the process and the procedures, as we all know in clinic, we have a lot of processes, procedures, workflows, all those things of getting newly diagnosed patients on ART. The Rapid Art Toolkit guidance provides considerations for immediate start or 7-day start. We will share that toolkit with you before we end our session today. As we all know, each clinical environment is unique, and it's important for clinics to plan out a unique rapid art policy, procedure, or workflow that really fits your setting and your capacity. Immediate start includes starting the patient on ART the same day as a reactive HIV test or when returning to care. I'll just add here also This is in lieu of waiting for your confirmatory testing. The current best practices recommendations now are to, if a patient is ready and willing, to get them started the same day and still do your confirmatory testing. And then immediately starting on art the same day does rely on, of course, some financial and psychosocial resources to support the initiation of art and ensure the patient is ready to begin art. We know in healthcare we get nothing done without insurance, without pay sources, things like that. And then one benefit we think of in starting art immediately, like that same day, is the lower risk of of losing a patient to follow up because they're there, they've started, and in many cases, they'll likely continue. All right, let's go to 7-day start. For a 7-day start, again, a patient would be prescribed ART a few days to 1 week after a positive HIV test or returning to care. One of the main benefits of this approach, of course, is allowing the patient time to get those resources, right? We talked earlier about psychosocial evaluation and resources, navigation, all of those things folks might need as they're preparing to start their HIV treatment. And however, there is a greater risk that the patient may be lost to follow up. This also can include, depending on their setting, how easy is it for them to get back to your site. Sometimes folks don't have phones that are working, or you just lose contact. So we hear all of these stories as we work with our clients across the country who are serving communities. So now we have a question for you again. Again, you can pause the video and put some thoughts down on paper just so you can refer back to this after we're done. So, and we mentioned one already, but what are the benefits of that immediate start? It's the same day the person's just found out they have HIV and they're going to start their meds the same day. Write down a few, 2 or 3 ideas about what the benefit is of that. That's great. Hopefully you came up with some ideas. Things we think about, of course, is that lower risk of losing patients to follow up. They're going to get that viral load down quicker, which is a benefit to their health, and also the benefit of less likely to transmit HIV. So we know there's some great benefits when we think about that immediate start. All right, and now, same thing, pause the video, write down a few ideas about what are some of the challenges that you might run into with immediate start. Give you just a few minutes to write those down. All right, that's great. So some ideas, again, that we think about are patients may not have the financial resources to start. We talked about that can be a challenge if they can't access the meds because of financial barriers. The program may not be able to link folks to care immediately. Sometimes that's not as seamless as we would like. And of course, there's regional issues, like I spoke earlier, frontier, rural communities where getting to the location where you access treatment, et cetera, can be challenging. And you think about innovative strategies where sometimes you want to work on some partnerships that will help with that. And this we also have in that Rapid Art Toolkit. We have some great resources for you. All right, guess what? Another question. We have a lot of questions today, but also want you to think about, again, you can pause the video so you can write some things down. Now, what are some benefits of a 7-day start? So having a week to get folks into care, to get that financial, coverage set up. What are some of the benefits you think of? All right, thank you. So some of the responses could be more time to gather resources. The patient has more time to prepare, like if you think about the idea of being given a significant medical diagnosis, any diagnosis, it takes some time to process that. So that's the beauty of that 7 day. You at least have a few days to think about this and think about, what does this mean for me? What am I going to do next? And you can get that confirmatory test done. So there's definitely, you can see how there can be some benefits of having that 7 day window. Now, same thing, pause the video when you're ready. What are the challenges of the 7 day window? We've got a whole week now that things can happen. So, what do you think about that? All right. So, again, we think about um, you could lose the patient to follow up, right? That's the first thing that comes to mind. The viral load's not decreasing, right? So there's that, window of time where HIV could be transmitted. So we talked about that national strategy, wanting to reduce new HIV exposures, basically. And then, of course, the same thing with regional issues. In a frontier rural area, we think about, what could be a challenge in the 7 day start. And it would be the same thing, because sometimes, even I think of our folks, especially in frontier communities, it could be a few weeks, not just like a week, but a few weeks or a month to get things coordinated and get someone kind of moved around to access treatment and care. But there are some great strategies such as telehealth and connecting with community pharmacies that you'll again find in that rapid ART toolkit. All right, so I'm going to pass it back to Ms. Jai and let them share about linkage to care activities.
Awesome. Thank you so much, Bev. So, some of the things that I want to share with you are the linkage to care activities as they relate to rapid ART. As a caveat, not all programs may do all of these activities because there might be structural barriers or financial barriers for the organization. But linkage to care, we know, is a critical HIV navigation service activity. And the goal of that is to link persons who are newly diagnosed with HIV to medical care and ART as soon as possible. Because rapid ART is getting folks started on medications faster, it shortens the window for linkage to care activities, which means that several of these activities may need to happen during one visit. At a minimum, programs should have someone who can provide linkage to care services and act as the primary contact to get started with services. All programs should aim to create a low threshold for engagement by limiting the number of handoffs and prioritizing a warm handoff whenever possible. So, a warm handoff being introducing to the next step, or introducing to key staff members, or introducing to key collaborative staff partners as well. Having a primary contact helps to reduce the number of handoffs, and it also to prevents confusion on getting enrolled in care. So, as Bev mentioned earlier, receiving medical diagnosis and big medical news can cause a lot of hesitancy. It can cause some confusion as well. If there is one staff member who is responsible for helping you connect to care, and that is the primary contact and the primary point, then it becomes less confusing for the patient who is also grappling with a new diagnosis. An LTC staff member is one of the first staff that should be speaking to a patient who are newly diagnosed, and should also be able to provide post-test counseling, some HIV education, and offer support in understanding the new diagnosis, especially as this person is continuing to digest and understand what this diagnosis means for them. LTC staff should also be assessing barriers to care that may delay seeing a provider, starting on medication, or maintaining their care. So, this psychosocial assessment may include identifying and providing any appropriate referrals that will help to alleviate or address some of those barriers to care. Obtaining baseline labs is a vital part of the rapid art process, as was mentioned in that workflow that was shared before. And so your workflow for your program and for your rapid art program should be developed to ensure that linkage to care staff are aware of timeframes for baseline labs for either the immediate or the 7-day start process, and when we're trying to get patients to get those confirmatory labs. And then because this information can be new and overwhelming, linkage to care staff should also be available to accompany patients to laboratory visits, to medical appointments, to referral intakes, anywhere that they might need to be going in order to get their care needs met. The purpose of these steps and the purposes of accompanying patients is to ensure that patients remain engaged in care and are not being lost to follow up. Additionally, a hands on approach allows for early intervention if there are any missed visits or challenges with picking up medication. Here are some of the examples of linkage to care activities for both an immediate antiretroviral therapy start and also a 7-day rapid start model. The activities and timelines may vary depending on the client or the context of the program, but generally, staff assigned to provide linkage to care should meet with a newly diagnosed client on the same day as a positive HIV result. During that meeting, staff would determine whether the client is eligible for and would be ready to participate in rapid ART. They would provide post test counseling, they would obtain a confirmatory lab. If the client is ready, then additional linkage to care activities, such as an insurance assessment, could occur. If the client does not start immediately, this initial visit should include scheduling out the initial ART intake visit. During a second visit, the linkage to care staff will review confirmatory labs with the patient, assess barriers to care, and develop a long term care plan. If the client has started ART, then this would be a time to follow up on previous linkage to care activities. If not, then this is when the assessment would take place in order to figure out what those additional activities will be. A third visit can include refining a long term care plan, some ongoing insurance assessment, or addressing new barriers as they come up, and addressing any persistent barriers to care as well. Again, because program capacity and client context can shift, and because we're oftentimes working with folks whose context is shifting even between the times that we are talking to them for engaging in care, these timelines may not exactly match what is available for your organization. But determining the process for referrals to linkage to care and creating a well-defined workflow for clinical and non-clinical roles can improve how quickly clients are linked to antiretroviral therapy. Whoops. And with that, I'm going to pass it back over to Bev, who's going to talk about initiation and provider follow-up.
Great. Thank you, Ms. Jai. So this is a great kind of next step in our conversation. We're still considering and understanding that you all have unique settings. You have everything that goes on in your space is unique to you. It's unique to your region, to your funding, all of those different things. But we do have some recommendations as we consider things, if you can do them, are really helpful for folks who are initiating. So if your clinic, for example, has ART on site, it can be really beneficial for the patient to take that first dose in the clinic under what we call DOT, or directly observed therapy. You may remember that from TB treatment if you've ever been involved in that. This allows the patient to begin the medications, again, the same day you prescribe them, be it initially or 7 days, that kind of doesn't impact it, but it does get them on the meds the day you actually write the prescription, and they have support. What we've heard is that patients really value that support for that first dose. Again, it is a recommendation, not required, because it's not always feasible in every setting, right? So remember, a variety of team members can participate in supporting, like your clinicians, your pharmacists, your case managers, linkage to care staff, or other identified team members. So that's one of the things we highly recommend is look across your team and start to plan and strategize around who could help with what piece of the rapid ART initiation process. A brief check-in at 24 to 48 hours can be done, again, easily as a phone call or a video visit. This is to check patients' well-being because this is all new, and there's a lot of adjustment going on for the patient psychosocially as well as in other ways. Again, we want to ask questions. We want to continue counseling. After folks have had that diagnosis, they may not remember everything you said that first day because we become psychologically overwhelmed when we hear news like that. So again, you want to repeat those messages so folks understand what's going on. Again, this can be across the team. You can have a case manager, you can have a medical assistant, other folks on the team assist with this visit. It's recommended to have one of your clinical team members available in case clinical questions come up or side effects, things like that. You want to be able to address those right away. Again, this allows us that opportunity to address and focus on psychosocial needs. And lastly, at this clinical visit, baseline lab results should be back when you see them around 1 to 2 weeks. So you can give folks a more broad picture of how their health is doing, see how they're feeling on the medication. Hopefully things are going smoothly and they're starting to see that, oh, this, I think I can do this and I think it'll be great. Again, this is an opportunity to continue to evaluate for complications. Again, clinical providers are always ready and prepared to address those things. And we want to monitor throughout these different time points the psychosocial needs and think about resources and who else could we refer our clients to. So we have, believe it or not, a question for you. So again, you can pause the video for a few minutes and write down what are some of the considerations we need to evaluate for to make rapid ART successful. So think about your linkage to care activities that Ms. Jai went over, the time frame for clinical follow-up, and think about the clients you're engaging. So in your care settings, think about what do you need to evaluate for rapid ART to be successful? All right. Hopefully you came up with some different strategies. They'll be unique to your environment. You may need clinical staff to be available at different times that they weren't before. You may need to set a person who's on call for rapid ART. There's so many things. You may need to work with your pharmacy and see, can they have the meds on site so you could do that first dose in the clinic. So many things you could do to, again, evaluate and start to measure, like, what can we do to move this along? So I'm going to turn you back to Ms. Jai, who's going to walk us through a few more considerations.
Awesome. Thank you, Bev. So to initiate, we're going to talk about different site locations for initiating rapid ART and some of those considerations. So for telehealth, to initiate ART, rapid ART, some visits and activities can be completed remotely if it's more convenient for the client or program. I think about for our folks who are in rural areas, frontier areas as well, though sometimes there are spaces that don't allow for a cell phone tower or like have cell phone service or internet service, which can make it difficult for telehealth. But if you are using telehealth, it is recommended to review what technology is available, have a staff member that's trained in the technology, and have that staff member provide technical support when it's needed and be available for technical support during telehealth visits. Additionally, you're going to want to account for HIPAA requirements, how you will collect paperwork, and any challenges with the patient accessing the technology platform. So make sure that the platform that you are using is compliant with HIPAA. For community-based pharmacies, these can include neighborhood pharmacies and supermarket pharmacies, or they may be located within a larger health system, like an outpatient pharmacy at a hospital. So initial testing can take place at community pharmacies. Then through partnership, complete confirmatory testing and linkage to care activities. Bev mentioned this a little bit, that there are some standards of work that are available and sometimes MOUs that are developed in order to allow point of care rapid testing at community pharmacy locations. And more information is available about that through the toolkit. It is recommended that community pharmacies do work with health departments or clinical prescribers through a collaborative practice agreement. The CPA allows qualified pharmacists within the context of a defined protocol to assume professional responsibility for patient assessments, for ordering labs, and for initiating medication, all of which can improve time to viral suppression. For urgent care and emergency departments, since follow-up will likely happen outside of this setting, providers should consider prescribing a limited supply of medication, so for example, a 7-day supply, and then facilitate timely follow-up in the setting where the patient will receive HIV care, whether that be through a specialty clinic within the same hospital network, or if they're connecting to a local provider that provides HIV care and management. After initiating ART in a clinical setting, it would be acceptable to prescribe up to a 30-day supply of the medication and then and also provide a follow-up appointment. We talked a little bit about timeframes for those follow-up appointments as well. If the setting does not have HIV care integrated into clinical operations, the patient can be transferred to an HIV continuity of care clinic after the 2-week follow-up appointment or sooner. So prescription might be able to take place, and then we could connect them to an appropriate management care environment. And then for non-clinical settings, or which are any settings outside of a clinic where HIV testing is available. So this could be our mobile testing sites, it could be community-based organizations. Several partnerships are needed to successfully initiate ART in a non-clinical setting. So it's recommended to create collaborative agreements with health departments, with pharmacies, with clinics as appropriate in your service area. This is to ensure a quick obtaining of confirmatory testing, followed by referral to a clinic um, where HIV care and management can take place, and or referral to get that first script as well for the medication and begin rapid ART. So these recommendations and more are outlined in great detail in the Rapid ART toolkit that Bev is going to share with you right now. Please feel free to also pause this and use the QR code.
All right, everyone. So we've been talking and talking about this rapid ART toolkit because we're very fond of it. We helped to develop it with the CDC. So this toolkit again was a partnership. We worked with the CDC along with capacity building assistance partners, which Denver Prevention Training Center is one of those capacity building programs in the U.S. And we all collaborated again, to try to put the most information in here that can really help programs who are either initiating a rapid ART program or enhancing one, or even starting to plan for one. There's so many great resources here. You can access this toolkit. Again, use this scan code. If that scan code doesn't work for you, if you go to denverptc.org, and we're going to share some other scan codes with you where you can find the toolkit as well. But again, as you can see, it's going to take you through initiating ART, HIV navigation services, cost, and program financing, which we talked about. We really have to be ready for that. And then training and technical assistance. So we hope you will actually pull up this toolkit. You can actually print it out if that's helpful, or print out the sections that are most relevant to you and your team. Right.
Awesome. And then these are the QR codes for you to connect with us on social media, or directly through our LinkedIn, our Facebook, or Denver PTC's website. And if you have any questions, you can also submit questions through those spaces to get a hold of us, so that we can provide you some support around Rapid Art, or anything that we have covered through this video. And with that, thank you so much.
Thank you.